Hello, everyone, and welcome to the Parkinson's Foundation's Wellness Wednesdays webinar. Thank you for joining us. We will begin in just a moment. For anyone who might be new here, please let us know in the chat so we can say hello to you and perhaps share where we are joining from today. I'm in the Western North Carolina region. The clouds are in the sky, it's warm, and the air is a bit humid. Please know that everyone will be muted for the duration of today's program. We'll have a short introduction before the presentation, and we will have a live question and answer session. So feel free to submit any questions that you might have around longevity and progression of Parkinson's disease in the Q&A feature, and we'll address as many questions as we can during that Q&A. If you have any technical challenges during the webinar, let us know through the chat and we'll respond as quickly as possible. Please know we are recording today's presentation and you will receive a follow-up email from us with a link to today's recording and the slides in about 1 week. It's officially Parkinson's Awareness Month. This year, we'll be sharing the ABCs of PD to spread the word about Parkinson's disease from A to Z. Follow along this month as we highlight one aspect of PD for each letter of the alphabet. Find resources or help spread the word about Parkinson's disease by visiting parkinson.org/awareness. The Parkinson's Foundation is a nonprofit focused on bettering the lives of those living with Parkinson's through improving care and advancing research. Importantly, everything we do is in close concert with our community to ensure that our actions are aligned with the needs and priorities of those living with and impacted by Parkinson's disease. Today's program will explore why people with Parkinson's progress differently, how to live well in the marathon of PD, and how treatment and care needs may change over time. PD Health at Home is presented by the Light of Day Foundation, whose generosity has made this programming possible. Thank you, Light of Day. The Parkinson's Foundation provides weekly education and wellness programs virtually through our PD Health at Home series, including Mindfulness Mondays, Wellness Wednesdays, Fitness Fridays, our expert briefing series, and our Spanish language programming, Y Salud en Casa. On May 1st, join us for our social engagement series, where we will explore movement for Parkinson's. Join our global program where esteemed dance professionals from Southern DanceWorks lead sessions focusing on unleashing the full potential of physical and artistic movement. You can find out more and register for our PD Health at Home events at parkinson.org/pdhealth. To begin our formal presentation, I'd like to introduce today's expert presenter. Dr. Danielle Larson is a movement disorder neurologist at Northwestern Memorial Hospital, where she completed her residency and fellowship training after completing medical school in Boston. In addition to seeing people with Parkinson's in clinic, she is involved in PD research, being an investigator on clinical trials. Dr. Larson, it's such an honor to have you here today, and thank you for joining us.
Hi, thank you so much for the introduction, and thank you everybody for joining today. It's my honor to be here and give this talk today. This is definitely a very important topic and something that comes up pretty frequently in clinic from people with Parkinson's and their family members and their caregivers. So I'm happy to go over this information today, and hopefully it will answer some lingering questions and thoughts that you all have. And we'll have the Q&A session at the end too to hopefully address any further questions that I do not cover. All right, so first, I don't have any conflicts of interest related to this presentation to disclose. The learning objectives for the next 40 minutes or so that I'll be speaking is to help with an understanding of why people with Parkinson's have different paths of progression. Also, to help you learn when and how to adjust things such as medications, exercise, therapies to help address changes that can be seen in symptoms. I also want to help you be able to recognize when it's time to talk to your provider or your care team about the changes that you're noticing or experiencing so that you can have changes in your medications or therapies adjusted along with those changes to keep your symptoms the best controlled, your quality of life the best that it can be through, like was put so appropriately, the marathon of Parkinson's disease. So to start, I just want to provide you kind of with an overview of the progression that we would typically expect for Parkinson's disease, something that we would call the natural history of the disease. What do we expect it to look like for somebody over their lifespan? So, in general, we always tell people that Parkinson's disease is a slowly progressing condition. It is progressing, meaning that the symptoms of Parkinson's are getting a little bit worse, little by little, but that rate of change is slow and gradual. I always tell people in my clinic that you will not all of a sudden have a sudden precipitous change in your symptoms. You will not all of a sudden fall off the cliff and start noticing a lot of symptoms. You'll start just noticing things little by little, day by day, very gradually. There is some difference individual to individual what exactly that rate of change is. Um, some people might experience changes over 20 plus years, while others might see changes a little bit quicker and, as such, might need medication changes a little more often than others. Because everybody has a unique form of Parkinson's. As you might know from meeting other people with Parkinson's and other caregivers, everybody is unique in a little bit in the symptoms that they have and how those change over time. One difference that we do see that can impact the rate of change or the rate of progression from person to person is that there is a loosely defined subtype of Parkinson's called tremor predominant, and that's a type where people first notice the tremor on one side of the body, and tremor really is the dominant symptom that that individual experiences. It that those people that are deemed tremor predominant do tend to change even slower than the typical slow rate of progression. Whereas other people who don't have the tremor at the beginning and tend to have more noticeable changes in their gait or balance or more frequent falls in the first couple of years of their symptoms, they might tend to have a little quicker progression than we tend to see on the slow scale of progression. So that's one thing that can help us differentiate from individual to individual the rate of change we might expect to see. Now, just to briefly touch on life expectancy for Parkinson's, this is also a common question that people have, and it varies from kind of study to study and population to population, and it can be something that isn't always consistent in terms of the exact numbers, but life expectancy is essentially marginally reduced compared to the population without Parkinson's disease. Again, it varies from person to person and can depend on a lot of things, which I'll talk about in a second. But just for one example, in one study that looked at longevity, one small study found that the average time from the appearance of the symptoms to passing away was 16 years. And the average age of longevity was 81, which is actually better than our expected longevity, at least for the United States. So again, it varies a little bit from study to study exactly what the longevity to expect is, but it can be on par or marginally reduced compared to people without Parkinson's. So for that individual variability, what are some things that can affect that? So one is the age of onset of symptoms. So people that have symptoms onset when they're younger than the typical age of onset, which is about age 65. So people that are diagnosed before that or have symptoms before that might see their longevity a little bit reduced compared to somebody without Parkinson's. The other thing that tends to impact longevity towards the later stages of the condition is the presence of dementia or symptoms of psychosis, which is what we mean by things like hallucinations or delusions or agitation. And then, of course, every individual has their own other medical history as well, and could have other medical conditions that can impact longevity. So that always makes it difficult to say specifically that it's the Parkinson's that shortens somebody's life. There could be other medical things going on that can contribute to the variability that we see in longevity. So now I want to just give an overview of the course of progression. What do we typically expect to see as somebody goes through the years, decades that they're living with Parkinson's disease? So most people um, have very slow onset of their symptoms, and a lot of people that right at the beginning symptoms are pretty subtle, so they typically go a couple years with symptoms before they're even diagnosed. And then typically for the first several years after the diagnosis, people are do very well, have significant improvement with medications at relatively low doses, and things are managed quite well. Um, Over time, because the underlying level of dopamine is gradually reducing in the brain, that's part of the natural course of Parkinson's disease, because that dopamine level that the brain is producing is slowly lessening. The need for medications to supplement that dopamine is increasing. So that's what's gradually happening over time. The medication doses need to be adjusted, need to be increased to supplement that dopamine. Due to needing more medicine to supplement the dopamine, at on average, the 5 to 10 year mark after diagnosis is when things get a little more complicated with managing the symptoms. So that's when, and I'll talk about this in a little more depth, things like motor fluctuations, when the medications don't last quite as long in terms of improving the symptoms from dose to dose, and the side effect of dyskinesias or involuntary movements start happening. Um, Around the 10-year mark is when we typically start to see more difficulty with balance, start to see some falls emerge due to something we call postural instability, where that righting reflex to correct our posture when it is challenged during walking or turning or definitely on uneven surfaces, when that is compromised, that leads to falls and imbalance. It's also something to note that people that are young onset Parkinson's are more likely to experience motor fluctuations potentially earlier in the course of their condition. So this is just a schematic of the progression that I talked about. So if you looking at time for zero, that is when the motor symptoms start. Anything before time zero in the course is actually what we call prodromal or non-motor symptoms that can actually occur before the motor symptoms even happen, but are related to the underlying condition. And those are constipation, REM behavior disorder, which is acting out the dreams and sleep, and other things like decreased sense of smell, and sometimes mood changes as well. But at time zero is when we say the motor symptoms are starting. And the main motor symptoms that we are seeing are the tremor, rigidity, which is stiffness and movement, bradykinesia, which is slowness and movement, and other common symptoms that can be seen are fatigue, pain, sometimes mild cognitive impairment. That's what an MCI means. Then you'll see that this graph is showing what I talked about, kind of beginning around the 5 year mark is when those motor fluctuations and dyskinesias start appearing. And then between the 10 and 20-year mark is where the some of those non-motor symptoms like trouble with memory, dementia, and then, like I talked about, psychosis, meaning hallucinations and delusions, can start to be seen, either as part of the disease or potentially as medication side effects. And there's definitely some variability in this, right? This is not a hard and fast rule by any means. And I definitely want to point out that not everybody with Parkinson's experiences dementia. Not everyone with Parkinson's experiences psychosis. So this is not a part and parcel of the condition, but it is something that the risk of experiencing increases over time. Um, as people get into their older age, late 70s, 80s, is when we would tend to see those symptoms come up if they are going to come up. Um, so one way that the progression is um, denoted either clinically or through research is by giving PD stages. So this is a common question that I get in clinic, what stage Parkinson's am I? And I wanted to touch on the PD stages, which are called the Han and Yar PD stages, just so everyone has a general sense of what it means, and that it's very it's not like a very detailed staging system. It's kind of a overall general sense of how people are doing. So it doesn't portray a lot of information. So that's why I try to tell people in clinic, like, try not to get hung up on the stages and what stage you are, because um, that doesn't necessarily indicate, how you feel and how you feel that you're functioning and how your quality of life is. Those are the important things that you talk about with your provider and your care team. So those things aren't necessarily reflected by the stage. But just so people have a general sense of what the stages are. So for the Han and Yar staging system, it's staged from 0 to 5. Um, 0 is no symptoms. 1 and 2 you can think of as early stage. So stage 1 is when we see the symptoms on one side of the body. So the symptoms are always start just on one side of the body. Stage 2 is when we can see the symptoms on both sides of the body. Stage 3 is when we start to see some changes in balance. And when we do an examination, we test for the postural stability, and we test for balance. And if we start to see that that is impaired and there's some stumbling or there's reporting of falls, that's when things are stage 3. Stage 4 is a little more advanced balance impairment, more significant falls. People might start to be needing a cane or a walker to help with stability. And then stage 5 is more advanced, where a person is typically needing a wheelchair to avoid more significant falls. So now that I've talked about the progression and what we typically expect to see, I want to spend a good amount of time talking about how we feel that we can change the progression, and to say that there are things, in your hands, with our help, with your care team's help, that you can do to try to change the underlying progression and hopefully slow it down even more. It's already a slowly changing process, but we do think there are things you could do to just slow it down even more. So a big thing is exercise. So exercise, we know, helps improve the symptoms. So if people are having, stiffness or pain or imbalance, exercise, physical therapy definitely helps with the symptoms. But we also think that exercise, and especially high intensity exercise, can be what we call neuroprotective, meaning it helps keep the brain cells healthier longer. So the goal is to keep those dopamine producing brain cells or neurons healthy. And that by keeping them healthy as long as we can, we keep the levels of dopamine um, from from uh, from diminishing at a faster rate. So we slow that rate down. So some of you might have heard of the Spark 3 exercise study, which is a very large study going on right now that's trying to prove that high intensity exercise can actually slow down the progression of the disease. So what I mean by high intensity exercise is anything that is aerobic, getting your heart rate up, breaking a sweat, feeling a little bit out of breath. So if you want to be very precise about it, there is like a calculator you can use to calculate your maximum heart rate based on your age and your sex and your weight. And then for high intensity, it's trying to achieve 80 to 85% of your maximum heart rate while you are exercising. And we recommend doing that at least 3 times a week for 20 to 30 minutes, getting that heart rate up. But I tell people they don't have to really be that precise about it, but just feel anything where you feel like you're breaking a sweat, you're losing, you're out of breath a little bit, is in that aerobic, higher intensity zone. So that's really what we believe has an impact on progression and hopefully will be proven with the Sparks 3 exercise study. But regardless of whether or not it is changing the actual progression, exercise we know helps with symptoms. So it should really be part of the treatment plan. Um, Another area that we get a lot of questions about is whether or not diet can change the progression of, of Parkinson's, or if there's a specific diet that is recommended. So in general, we recommend a healthy diet, but there are specific diets that have been shown to make a difference when they are adhered to. So one specific diet is called the MIND diet, which is like the Mediterranean diet that probably a lot of people are familiar with, which promotes whole foods, that is emphasizing seafood, vegetables, um, nuts, legumes, and healthy fats like olive oil, and avoiding things like dairy, butter, um, refined carbs, things like that. Um, and this diet was kind of created in 2015 to try to refine the Mediterranean diet a little bit and actually trying to promote brain health in an effort to minimize cognitive decline. And minimizing decline and preserving memory is an area that it has been looked at closely. And the thought is that this diet works at the cellular level. So again, at the brain cell level, to protect brain cells from neuroinflammation. It's an anti-inflammatory, thought to be an anti-inflammatory diet that again keeps the brain cells healthier longer. And in Parkinson's, that's the name of the game. Keeping the dopamine producing cells healthy as long as possible to keep those dopamine levels up. So, there is some there is some evidence that the MIND diet might actually slow down the progression of Parkinson's. So there was one study that looked at about 700 people that were, between 60 and 100 years without Parkinson's disease at baseline. And they were tracked over years to see if they developed Parkinson's disease. And then their diet was also tracked. And in analyzing this data and controlling for other things like age and sex, and if they smoked, um, and any other symptoms, it was found that people that adhered to a mind diet and had a high score of adhering to this diet actually had a decreased risk of Parkinson's, and people who got Parkinson's had a slower rate of Parkinson's progression. So I find that pretty encouraging. Um, the other area that it has been shown to provide a benefit is with cognitive impairment or dementia. So, in a pretty large analysis of different, like kind of pooling data from different studies that looked at thousands, hundreds of thousands of participants, it showed that this adhering to the mind diet was associated with a lower risk of dementia and even up to 17% lower risk of dementia compared to people that had a lower adherence to this type of diet. So again, I find this data especially with these large numbers pretty encouraging that it does have an impact. Now, I'm just going to briefly touch on supplements because this is a common question that I get. And in general, what I tell people regarding supplements is that a lot of things have been studied for Parkinson's and have basically not been shown to show any particular benefit on either symptoms or the rate of progression or the change. So things that have been specifically studied and shown to not be of any particular benefit have been vitamin E, creatine, coenzyme Q10, and metoquinone. There are some things that have not yet been studied that are supplements that people might be taking, such as curcumin or turmeric and TUDCA. But these two supplements have been tested in what we call preclinical models, so not in people, but in things like cell cultures or animals that show potential benefit. And the thought is that, again, these are anti-inflammatory components, might be keeping the brain cells healthier longer. So when people ask me about supplements, one thing that I say is turmeric, not going to hurt you. Incorporate it into your diet. There's turmeric teas you can buy. There are turmeric supplements you can buy. But just given that the data has not really overwhelmingly been in favor for any of these supplements, I generally tell people, um, you know, depending on the price point and how much you're kind of willing to spend, if things are significantly expensive and they haven't been proven to be of benefit, I would not highly recommend those. So I'm going to move on to talk a little bit more about more middle and advanced stages of Parkinson's disease. What are some of the changes in your symptoms that you can expect to change and expect to see so that you can better be on the lookout for these things so that you can be a partner with your care team to describe changes that you're seeing so that medications can be adjusted, therapies or different strategies can be used to maintain good symptom improvement and good quality of life. So, as I mentioned earlier, um, roughly between 5 to 10 years into the condition is where we start to see what we call the motor fluctuations and the dyskinesia. So what we mean by motor fluctuations is the fluctuating between on and off time. So on and off time is probably something that you either have experienced at this point or have read about. Um, and just to explain a little what that means, what we mean by on time is what we mean after you take a dose of Parkinson's medication, typically levodopa is what we're talking about. After you take levodopa and you feel the symptoms of Parkinson's um, resolve or at least significantly lessened, that's when we say you're on or it's on time. Okay. And then when the medication's effect is kind of wearing out, when it's getting towards the end of that dose, and then you feel the Parkinson symptoms return, that's what we call off time. And that dipping down from feeling good, from feeling on, back to feeling like all the Parkinson symptoms are back is what we call wearing off. So that dose of the levodopa is wearing off. So at the beginning of the condition, sorry, at the beginning of the condition, from dose to dose, usually levodopa works for a good 5 to 6 hours. So people feel a good 5 to 6 hours of on time the medication is working. And that's why we start with the medicine. Typically, you take it 3 times a day. But over time, over years, because of the underlying changes that are happening in the brain is losing the dopamine cells, but it's also losing the ability to handle dopamine well. So even though you're taking dopamine supplement by a pill, the brain isn't very good at using it. So a typical dose of levodopa is no longer giving a good benefit for 5 to 6 hours. It might start going down to 5 hours, then 4 hours, then 3 hours. So that's when we have to change the dose to more frequently, decrease the interval, the timing to keep that on time from dose to dose good and lessen the off time. So just to highlight it again, off time is what we experience between the doses of levodopa when either you've taken the pill and you're waiting for it to kick in, you're waiting for those symptoms to start calming down, or it's towards the end of the dose and you're seeing those symptoms return. Um, During off time or the wearing off time, symptoms can sometimes be mild and not very bothersome. Um, Other times it can be quite significant. It all depends on what symptoms people have. Some people also have what are called non-motor symptoms during off time. That can be anxiety um, comes out when people feel the medicine wearing out of their system. So, when should you tell your provider about the off time? So, whenever the off time, you're noticing a significant amount of off time, or you're noticing that the symptoms are quite significant when they return, and impacting your day to day, your activities during that time period, or impacting your ability to want to get out of the house and do things during that time period, or just impacting your quality of life, even if it's for 30 minutes, you should tell your provider because there are things that we can do to adjust the medicines to help reduce this off time. So strategies that can be used to reduce off time would be increasing the frequency of the levodopa. So reducing that interval, for example, from every 3.5 hours to every 4 hours to make sure that the on time is from dose to dose. Another strategy is adding on additional medications, what we call adjuvant therapies, that they're not as strong, they're not as potent of a dopamine supplement as levodopa, but they typically work to to boost, I call them kind of like dopamine boosters, to boost the dopamine that is being given by levodopa to help it last a little bit longer. In general, pretty much all the different adjuvant therapies that are on the market add an additional 1 to 2 hours of on time per day. So they aren't they they don't give a huge change in the amount of off time, but they could be a good option if people are just experiencing 30 minutes of off time between doses. Adding that adjuvant might take care of the majority of that off time. Another strategy that I forgot to put here would be changing if you're taking an immediate release form of levodopa, which is called Cinemet, changing it to a more extended release form of levodopa called Rytary, which typically lasts more like five hours or so. Um, And then there's also the option of on-demand therapies. So on-demand therapies are things like Apokyn, which is a self-injectable pen of apomorphine, or Inbrija, which is a form of inhaled levodopa. These medicines start working to control symptoms within about 10 minutes, and then they only last in the body for about 60 minutes. So we use them as kind of like a bridge between doses of the levodopa when symptoms are returning, so that it bridges the symptom coverage until the next dose of levodopa kicks in. So another thing to focus on for the moderate to more advanced stages is dyskinesias. So dyskinesias are purposeless involuntary movements, and typically look like fidgeting movements. It can be movements of the head, the shoulders, the hands, or the feet. And what these are is a side effect of the medicine, in that when levodopa is um, in the body and in the brain, it does have a peak dose where the dopamine is kind of surging and at its maximum. And at that point, that extra dopamine triggers the brain to cause these extra movements. So it's almost like the opposite of Parkinson's at that point, where Parkinson's is decreased or slowed movement, extra dopamine causes extra movement. Um, so we typically see dyskinesia start between 5 and 7 years into the diagnosis. Um, and again, this can vary, definitely vary from person to person, when the onset is and what the severity of the dyskinesias are. Um, Oops. So how to recognize and report dyskinesias. Sorry, this should actually say, instead of off time, it should say when dyskinesia is lasting long, or when the dyskinesia is getting in the way of things. Some things that the dyskinesia can get in the way of, if it's happening in the feet, it can get in the way of balance. Um, Sometimes if dyskinesias are pretty significant, there's a lot of like swaying movements, fidgeting movements, can actually burn calories, so people can actually lose weight. So those would be reasons definitely to tell your provider, because there are things that we can do. So reducing the levodopa dose can help with the dyskinesias, but also adding amantadine, which is really the only medicine that we have to help with dyskinesias, can reduce the dyskinesias. And there are two newer, longer acting forms of amantadine called Gocovri or Osmolex that can help with the dyskinesias. So another thing to look for with progression is changes in balance and mobility and falls. So things to look out for is changes in your balance, falling or even just near falling, which kind of tends to happen in tight spaces and crowds with turns on uneven surfaces. And then something that can definitely contribute to falling is what we call freezing. So freezing or freezing of gait is when people feel that all of a sudden their feet are stuck to the ground, they can't lift them up, they can't get going again. These are all things to tell your provider about. Things that you can do, one is adjusting your home. So setting your home up to help you to prevent falls is very important. Um, Setting up the home includes placing grab bars, specifically in the bathroom, by the toilet, by, getting out of the shower or the bathtub, so you have something sturdy to hold on to, can be very, very helpful. If you have a shower, something like a shower chair to prevent slipping. Making sure that the pathway to the bathroom at night is well lit. It can be very important. A lot of falls happen at night in dimly lit areas or tight spaces. There are even there are motion sensing, motion activated lights that I recommend. You can find on Amazon, just like everything else you can find on Amazon, that they're like night lights. They plug into a wall plug and they're motion activated. So if you have wall plugs in the bathroom or on your way to the bathroom, it can light up automatically for you while you're walking to the bathroom. So you don't have to worry about fumbling in the dark, fumbling to turn on a light. Um, Other things that can cause falls are loose rugs on the floor, tripping over the ends of rugs. And also, I usually ask my patients what kind of shoes they wear around the house, if they wear any, because slippers, especially slippers with no heel to them, no sole to them, with that actually causes resistance on the floor. Those can actually contribute to falling by either slipping or getting the slippers falling off, and again, you kind of stumble over your slippers. So think about what you're wearing on your feet. Um, and then if it's recommended that you by like your care team, your physical therapist, that you have a cane or a walker, definitely make sure you have that around. Use the walker inside the house. Have the walk if you can, have several walkers maybe at different places in your home so that you are primed to use them regularly. And then make sure you're telling your provider about these things because um, physical therapy, occupational therapy, and should always be utilized. So typically everyone's insurance covers so much physical therapy or occupational therapy for per calendar year. So we always want to make sure everybody's using as much as they can get each year. Even if the symptoms aren't necessarily that significant, doing a little physical therapy to retrain the balance centers of the brain is very important to do. I think everybody should do it at least once a year. Um, and then also ask your provider for any prescriptions for walkers or wheelchairs that might be necessary. Um, so another thing to talk about is cognitive changes that might be seen. Again, everybody is different. Not everybody gets significant cognitive impairment or dementia. Some people just have common memory changes like word finding difficulties, names, slow processing. Other symptoms that would be more concerning for possible development of dementia would be forgetting how to manage your medicines, your appointments, having trouble managing finances, or getting lost. So what you can do to help prevent any cognitive changes, or what you can do to slow the rate of change of cognitive changes is exercising your brain. So make sure you keep the brain active just like you're trying to keep the body active. So reading, doing crossword word puzzles, jigsaw puzzles, and social engagement is very important for the brain. So whatever hobbies it is you like to do, if you like dance, if you like music, if you like art, um, make it a priority to stay engaged with those activities, and ideally in a social way. And then exercising the body, as I already talked about, we believe is neuroprotective and keeps brain cells healthy, which will also help with cognition. And then make sure you tell your provider about any of these symptoms because we do have medications that help to try to stabilize any memory changes. And then also, speech therapists can perform cognitive exercises and have cognitive strategies for people experiencing memory changes. Um, so the last note of things to look for with the progression are changes in swallowing. So what can be common is feeling a little bit effortful with pills, a little bit maybe like things get stuck, but the food goes down, liquid goes down okay, maybe a little coughing on liquid. What is more concerning is if you're actually having episodes of choking on things, um, and have to avoid things when you're eating. So what you can do is just be mindful about what you're eating, how much you're eating, and how fast you're eating. So sit upright, eat slowly, take small bites. But definitely tell your provider because things we like to do right away if there's any difficulty with swallowing is have your swallow evaluated with a swallow study and have speech therapy because there are exercises that can be done to help you swallow more effectively and prevent the risk of aspiration. So, to conclude, the take home points with respect to longevity and progression. So, Parkinson's disease is definitely a slowly changing condition, um, and does not have a significant impact on longevity. Very importantly, you can help slow the change of Parkinson's disease with things like a healthy diet, specifically the MIND diet has some evidence that it can slow the change in Parkinson's, and exercise, again, specifically the higher intensity aerobic exercise. As the symptoms of Parkinson's disease change, it's important to work with your care team to report any changes you're seeing in your symptoms because medications and other treatments can be adjusted to help mitigate those symptoms and improve your quality of life. So you, your care partner, your family are part of your care team. So be vigilant for any change in these things that I mentioned and communicate it to make sure that we keep your rate of change slow and your quality of life high. Thank you.
Thank you, Dr. Larson. Really appreciate all the effort that you put into outlining longevity, first and foremost, and progression with Parkinson's disease. I know that this comes up regularly in the community. How will I change? How will Parkinson's affect me? One question I'd like to really hone in on is why. Why do people with Parkinson's differently?
Why do they progress differently?
Yes.
Yeah, so there are lots of different variability. Some things depend on the age of when a person is diagnosed, what other medical conditions they might have, as well as what their symptoms look like. As I mentioned, people that are tremor predominant tend to progress slower. Um, and the other thing could be like things I said, people have different rates of activity or healthy diet or exercise, and we do believe that has an impact on their rate of change.
Does genetics play a role in Parkinson's progression?
Genetics can. So first of all, most people with Parkinson's do not have a clearly genetic form. So 85-90% of people do not have a genetic form of Parkinson's. But for that minority, for that subset, one of the more common genetic genes that people can have a genetic mutation in is called the GBA gene. And it definitely depends on the exact mutation, but some people with the GBA mutation and a specific mutation can have a faster rate of progression than otherwise what we would typically see with Parkinson's.
Thanks, Dr. Larson. And the foundation has lots of information on our website, more about genetics and Parkinson's disease if you'd like to learn more about that. Our guest, Pat, shares that her exercise is quite limited due to joint pain. Do you have any recommendations for someone who experiences a lot of joint pain?
Yeah, I mean, that's definitely one thing that I did not mention in this presentation is that, there's an ideal amount of exercise um, and the ideal thing to do, but everybody is different with what limitations that they might have, be it other medical conditions, physical limitations, um, just mobility limitations. So, the most important thing is to stay active in your way that's going to be the most comfortable for you and the easiest to do for you. So there's no one size fits all when it comes to exercise. Um, so some things that people find helpful if they do have pain would be low impact exercises like uh, things in the pool actually. So there are some therapies and rehab centers that actually do like pool-based physical therapy, where you're not necessarily swimming, but you're just like in the pool. They're assisting you, but it does help with pain that might otherwise be caused by like higher impact or stress on the joints. So that would be one thing to consider. And then other things that can be helpful for people with maybe mobility or balance challenges would be using a recumbent bike so you don't have to worry about balance, doing things like chair yoga. Um, just the name of the game is really just keeping your body moving on a regular, consistent basis.
Thanks, Dr. Larson. And Pat did mention that she's going to be starting some pool therapy, so it sounds like she's on the right track.
Oh, wonderful. Good. Well, I hope you enjoy it.
We got a question about the stages, right? And I recognize that the medical field is working to steer away from staging people in Parkinson's. And it's also a nice image that the community likes to see to kind of evaluate where they are at as far as their progression with Parkinson's. It does, unfortunately, alarm some people to see the images that are associated with the different stages of Parkinson's. And one of our guests asks, does everyone with Parkinson's end their journey in a wheelchair?
No, I would say no, not necessarily, right? I mean, it definitely all depends on what that individual is like in their later years. So, Parkinson's aside, right, people in just the natural course of aging are going to have changes in their health, changes in their mobility that are not related to Parkinson's disease. So, I typically say that what ends up happening in the later years is just as much a result of that as it is Parkinson's disease. So, some people might need to be in a wheelchair because they have other conditions that are affecting their mobility, whereas other people that might be otherwise healthy might not necessarily have those same mobility limitations. And it might be, that other things that affect people's longevity other than Parkinson's, like cancer, heart disease, um, are what affects longevity more so than Parkinson's disease.
Thanks for clarifying that. And yeah, just continuing to encourage the community to live now, right now,
Hmm.
being alive for this day. We got a viewer, one of our attendees here, saying that they were diagnosed just 2.5 years ago and have terrible balance. Curious if this means that their journey through Parkinson's will end sooner, and what they can do when they have this experience of bad balance.
Hmm. Yeah. Yeah, it's a little complicated to answer in a general way, because everybody is very unique, and people can have imbalance for other reasons as well. So it's possible that for this individual, it might not just be the Parkinson's that is causing imbalance, right? There are a lot of other neurologic conditions, but also non-neurologic conditions that affect balance. So I'm not sure if any of that is at play, but I would assume and hope that their neurologist, if it's a movement disorder specialist, has looked for any other causes of balance that could be contributing to make sure that those are addressed. And then if it is Parkinson's related, then I would obviously medications can try to adjust balance, but if there is not, regular physical therapy being done, I definitely would say to do that as often as insurance would allow, is my rule, as much as you can to help strengthen all the balance centers and mechanisms of the brain and the body.
It's sort of relieving to hear that there are other things at play, right? It's not just Parkinson's that could be affecting our balance. And there are things that we can do to strengthen that mobility in our bodies outside of Parkinson's disease that we have access to. So thank you for that, kind of a little seed of hope, I'll call it, that there are things that we can do. Thank you, Dr. Larson. Gerald is asking, this is an age-old question, and I really think it's important that we talk about it. When we take our carbidopa levodopa, how it's associated to when you're eating, whether or not it's impacted by protein. So could you just talk a little bit about when someone should be taking their Parkinson's medications and how protein, the consumption of protein foods, might influence your PD meds?
Sure, yeah, this is definitely a common question that I get. So, what is happening with protein is that higher amounts of protein in the stomach at the time of taking the pill competes with the pill's absorption into the stomach, through the stomach into the bloodstream. So that's why, in general, we say don't take the pill close to having a high protein meal. So, in general, we say either take the pill 30 to 40 minutes before you eat that high protein meal or 30 to 40 minutes after you eat the high protein meal so that the protein has absorbed and is somewhat out of your stomach. That doesn't mean you if some people get nauseous with the pill, they can have other things that are low protein to help with the nausea, like a cracker, toast, things like that. And also, everyone is affected a little bit differently by this protein interaction. So some people might notice that they can take their pill close to eating a steak and they feel fine. They feel like the medicine starts working just as normal. Where other people might notice that if they take it close to that steak, that they feel like the medicine didn't work at all. So everybody is a bit different, but that's why in general we give those time frames of when it's ideal to take the pill.
Thanks, Dr. Larson. And again, it's this reminder that everyone is different, right? What works for your
Mhm.
peer might not work for you. So it's this ongoing experiment of finding the flow with medication, with food, with exercise that works and feels supportive to your needs. We've got time for just one more
Exactly.
question from Keith. Keith has asked, they've noticed overall improvement with the right arm shaking, their tremor. And in situations of anxiety or things that cause stress, the shaking begins again. Is there a relation between
Mhm.
tremor and stress and anxiety?
Yes, absolutely. So anything that makes you feel a little bit off your game, like stress, anxiety, fatigue, not having a good night's sleep, having a little too much caffeine that morning, or even good stress, like good anxiety, like you're going on a trip and you're excited about it, even that's just kind of heightening your nervous system a little bit. It just has you a little bit excited, and that's going to bring the tremor out. So that doesn't mean that the tremor is all of a sudden worse and is going to be worse and you need to change your medications. It's just going to fluctuate kind of based on how you're feeling within the day and potentially day to day. So you might have one day where you didn't sleep great the night before and the tremor is bothering you more. And the next day you might not see the tremor at all. So it's very common to see these fluctuations based on everything else in your body and in your mind about how you're feeling.
Thank you, Dr. Larson. And I want to address quickly with just an overarching response. We did get quite a few questions about sleep and Parkinson's, and want to direct our community here to join us for our expert briefing on May 8th. That is all about sleep and Parkinson's. So we'll get really deep into that subject. And Dr. Larson, perhaps you could provide just a few words to talk about the connection between sleep and Parkinson's disease.
Sure, yeah, I mean, there's definitely a connection, and Parkinson's can affect people's sleep in different ways. Some of the common ways that affects it is by causing REM sleep behavior disorder, which is with talking in sleep, acting out dreams during the REM or the dream stage of sleep. And then another way is it can cause what we call fragmented sleep, where people experience not necessarily difficulty falling asleep, but they feel like they're waking up on and off throughout the night and might have a little bit harder time falling back asleep. So that's just a primer of things that can be noticed, and I definitely would recommend people tune in to the more expert discussion about sleep.
Thank you so much, Dr. Larson, for your time today. Really appreciate the way that you're able to share about living long with Parkinson's disease and how we can continue to slow down the progression, whether that's the way we exercise, the way we eat, the way we engage with our community, and the way that we engage the medical professionals on our team. So thank you so much for your expertise.
All right, thank you. Thank you for having me.
Don't forget to visit our website, parkinson.org/awareness, to learn how you and your community can get engaged to support the Parkinson's awareness campaign. Everyone can participate at events on our website and on social media, find resources, or help spread the word about Parkinson's disease by visiting parkinson.org/awareness. If you had a question today that was not answered, please do not hesitate to reach out to us. We have a comprehensive website with many resources that addresses everything related to Parkinson's at parkinson.org, or call our helpline at 1-800-4PD-INFO, or email us at helpline@parkinson.org. I know several of you are new here to this community with the Parkinson's Foundation. We have an extensive amount of information for you, and the helpline can help you navigate on where to start or where to go next. Before you go, before you click that end meeting, you'll see the Zoom screen prompt a survey. Please know that our programming is fueled by your feedback. We appreciate you taking the time to let us know what you hope to learn and future sessions. So please take some time. Your words are read by my eyes and the team behind these productions. So please take some time to let us know what you wish to learn more about. Take care, and until I see you soon again, be well.